So coming to question 45, this is the last question of our PYNQ series. This is a 2023 nephrology question. So I have tried my best to compile the last 3 years question. There are 45 questions in total and it covers the various subjects. Mainly cardiology, neurology and respiratory system are covered, and in addition we have endocrinology, nephrology and rheumatology also. And while discussing some questions, I have made detailed notes about the important topics also. So revising these 45 questions will be useful before your NEET questions, NEET exam. So a 53 years old male patient was undergoing hemodialysis. Towards the end of the session, he became hypotensive and became drowsy. How will you treat this condition? First, what is this condition? Because at the end of hemodialysis, we remove most of the fluid, most of the electrolytes. So we develop something called as dialysis disequilibrium syndrome, DDS, dialysis disequilibrium syndrome. If only BP falls, that is post-dialysis hypotension. Suppose if they are given only there is hypotension, then we can tell that it is post-dialysis hypotension, because a large amount of fluid is removed. So it is very more likely that they can develop hypotension. So to reduce post-dialysis hypotension, we should skip that day's antihypertensives. Skip that day's antihypertensive. But they are given other findings also. Drowsy, sometimes they may have seizures, which means in addition to hypotension, in addition to water loss, there is also some changes in the electrolytes. Definitely electrolytes will be problematic because potassium is removed, bicarbonate is removed, sodium is removed. So there will be hyponatremia, hypokalemia, etc. So all these things leads to some behavioral changes that is called as dialysis disequilibrium syndrome. So how will you treat this? Volume is lost, electrolyte is lost. So you have to increase the intravascular volume and osmolality. So there are some special fluids for that. To treat dialysis disequilibrium, we can give fluids. So see the options. First option is furosemide, which is a diuretic which cannot be used in hypotension. Ethacrynic acid is also diuretic which cannot be used in hypotension. NORAD, definitely there is hypotension. Noradrenaline can be given to raise BP, but that doesn't treat the underlying pathology, right? So what is the pathology? We have to change the dialysis disequilibrium. IV mannitol. Whenever we see this question, we answer noradrenaline instead of mannitol, because we know very well one of the contraindications for mannitol is CKD, right? CKD, heart disease, volume overload. Mannitol is contraindicated because mannitol, being an hyperosmolar substance, when it is given in the blood, it will absorb all the fluid from the interstitium and the intracellular compartment, and it will swell up in the blood. When CKD is there, the excess volume cannot be excreted, so it is contraindicated in CKD. And excess of fluid is dangerous in heart disease. That is why in heart failure, mannitol is contraindicated, right? So when we see mannitol, we straight away think it's a CKD patient, don't give mannitol. But mannitol, even though it is contraindicated in CKD, it's a very well used in dialysis disequilibrium syndrome. In older textbooks, it is said that in rhabdomyolysis associated AK also, mannitol has a role. In newer textbooks, it is not given. In newer discussion, they say only dialysis is the option. But suppose if any scenario comes, rhabdomyolysis associated AK also, mannitol has a role. So at least remember one thing, even though mannitol is contraindicated in CKD, it is of use in dialysis disequilibrium syndrome because it is an hyperosmolar substance. It retains salt, it retains fluid when given IV. Okay, so we didn't discuss much about CKD in this series, so I'll just tell about CKD and some of its important discussions. So CKD, how they are classified. When do you say it is CKD? When do you say kidney disease is chronic? When some abnormality lasts more than 3 months. That is rise in creatinine or proteinuria if it is present for more than 3 months, or there is some structural changes in the kidney like a shrunken kidney which is lasting more than 3 months, then we call it as CKD. So we calculate something called as eGFR, estimated glomerular filtration rate. We calculate it by some formula such as CKD EPI, MDRD equation, and Cockcroft-Gault equation. Using these some formula, this formula will ask only few things like about the age, the sex, the weight, the creatinine levels in the blood. With all these things we calculate eGFR, because GFR can actually be measured by clearance tests like creatinine clearance test, inulin clearance test, but those are very invasive and costly, so it is not done usually. So instead these are some calculated GFR, estimated GFR. So if the estimated GFR is more than 90 ml per minute plus per meter cube, it is normal, or in other words it is CKD stage 1. The normal GFR is also more than 90, but CKD1 is also more than 90, because in early stage there will be compensatory hyperfiltration. So filtration will not be affected even in CKD. CKD2 it will be 60 to 90. CKD stage 3 is important because once eGFR falls less than 60, we should be cautious, because all medications, all treatments start from CKD stage 3. 3 is classified into 3A and 3B. eGFR 45 to 60 is 3A, 30 to 45 is stage 3B. Stage 4 is important, or stage 3 itself is important. 3B is important because our preparation for dialysis should start, because CKD is definitely a progressive disease. Okay, CKD is definitely a progressive disease. There is no treatment which can prevent the progression of CKD. So definitely they will end up in dialysis, but with some medications we can prevent the progression or we can slow down the progression. So 15 to 30 eGFR is CKD4. eGFR less than 15 is called as ESRD, end stage renal disease. Definitely this needs dialysis or transplant. So this dialysis or transplant is called as renal replacement therapy. Dialysis may be peritoneal dialysis or hemodialysis. So now we are commonly seeing CAPD, continuous ambulatory peritoneal dialysis. People are taught to do dialysis in their home itself. So the main important thing in dialysis, we have membrane. Patient's blood, in hemodialysis what is done is patient's blood is passed through a machine which has a filter. That filter removes the abnormal electrolytes, abnormal toxins, and it pushes back the normal blood into the cells, into the patient's blood itself. In PD, the patient's own peritoneal membrane acts as the membrane here. Peritoneum acts as the membrane, right? Okay. Now, what are the complications of CKD? I think this is more important because many scenarios can be framed by the complications of CKD. A person with CKD may be breathless. There are 4 reasons why a CKD patient can be breathless. One, it is volume overload. Pulmonary edema can occur. How will you treat? By IV diuretics or by doing dialysis, or we can do fluid dialysis. Yeah, right. So either diuretics or dialysis. Next, there can be acidosis, metabolic acidosis. CKD is one disease which causes high anion gap metabolic acidosis. It causes breathing difficulty without any changes in the lung. So we have to give bicarbonate supplementation, or in refractory acidosis we have to give dialysis. Then we have pericarditis. So this pericarditis also causes chest pain, and in pericarditis is very severe, it causes hemorrhagic pleural effusion, very typical for uremic pericarditis. There can be hemorrhagic pleural effusion. Even though tamponade is less likely, but it is a reason for breathing difficulty. So what else we can have? There can be hypertension, and hypertension can lead to pulmonary edema. Electrolyte imbalances are very, very common. Okay, electrolyte imbalances are very, very common. So why electrolyte imbalances are common? There can be hyperkalemia because potassium is not excreted by the kidneys. There can be hypocalcemia and hyperphosphatemia. Phosphate is a substance which is excreted by the kidney. When phosphate is not excreted, phosphate increases. Increased phosphate is a very important trigger for a hormone called as parathyroid hormone. So when phosphate increases, parathyroid hormone levels increases. So this is called as secondary hyperparathyroidism. If there is, what is primary hyperparathyroidism? There is an hyperplasia or adenoma secreting PTH. It is called primary hyperparathyroidism. But raised phosphate increasing parathyroid hormone is called as secondary hyperparathyroidism. What is the function of parathyroid hormone? To take calcium from the blood and bring it to the, take calcium from the bone and bring it to the blood. So there will be increased calcium. Even though calcium comes into the blood, the phosphate binds to calcium and it forms calcium phosphate. So this calcium phosphate can form stones in the kidney. Right? So that's why high PTH leads to the groin, moan, stone, pain disease. There can be abdomen pain. Hypercalcemia causes abdomen pain. Calcium phosphate forms the stones. When bone is eroded, there can be bone pain. So bone pain, groin, moan, stone disease. So when the secondary hyperparathyroidism lasts for a long time, the enlarged parathyroid starts secreting PTH on its own. It is called as tertiary hyperparathyroidism. The bone erosion in secondary hyperparathyroidism is called as brown tumor or von Reckling-Orson's disease or osteitis fibrosa cystica. So this is the bone complication of CKD. What are the other bone changes which can occur? Vitamin D, one step of vitamin D3 production is in the kidney. 1-alpha hydroxylation occurs in the kidney. So there will be vitamin D deficiency. And we discussed the secondary hyperparathyroidism, hypocalcemia and hyperphosphatemia. What happens to the blood? Erythropoietin is produced by the kidney. When CKD is there, there will be anemia because of reduced erythropoietin production. So if there is anemia in CKD, how will you treat? First is iron supplementation. So it is not erythropoietin which is given first. In any anemia of CKD, first you have to look for iron stores and correct the iron supplementation. Only then we have to give erythropoietin. I think this was discussed in one question. So and many other complications are also there. And uremic encephalopathy. When urea is high, it leads to uremic encephalopathy. So these are some of the complications of dialysis, complications of CKD. Now, do you have to do dialysis for every case? What are the indications for dialysis? One, there is anuria or oliguria. What is oliguria? Less than 0.5 ml per kg per hour is oliguria. Not every case with high creatinine you should do dialysis. There should be oliguria or anuria. There should be hyperkalemia refractory to treatment. How will you treat hyperkalemia? One is calcium supplementation. Why calcium? This excess calcium will stabilize the membrane and prevent arrhythmias. Second is insulin plus dextrose. It will push the potassium into the cells. Third is bicarbonate supplementation. Then potassium binding resins. Like K-bind, potassium binding resins are given. In spite of all this, if there is refractory hyperkalemia, we have to do dialysis. Next is acidosis. I told there is high anion gap metabolic acidosis. We give bicarbonate supplementation. If this is refractory to bicarb supplementation, then we have to do dialysis. Then encephalopathy, uremic encephalopathy or uremic gastritis or uremic pericarditis, these uremic symptoms need dialysis. So RRT, like renal transplant is also an RRT, can be live donor transplantation, live donor renal transplant or dead donor renal transplant, DDRT or LDA.